is going to be the CEO when we do open. We want to address where we're at, where we're going. There was yesterday or the day before, I don't know what day it was released from the Follett Press. It was a news release. The items in that news release, they are true, with the exception of maybe the header or the breaking news was we are likely not to open in 2025. That can be true, that can be false, and here's the reason why. When we came into this, there was a lot of stuff that we didn't know. I'm going to kind of take you through a small list of it, and then I'm going to let Tim here tell you what we have done. First thing we came here, we were turning the power on over there. We found that one of our predecessors left a bill with the Jellico utility district, and it was going to require us $80,000 deposit to get the power taken out of the city of Jellico's name over to Phoenix Rural Health. We worked with Joe Carroll and got that set up on a prepayment plan so that we didn't have to dish out $80,000 the first thing. So Mr. Carroll worked with us, and that is going well. The next encounter we found was our predecessors left a debt of $1.2 million. Part of it is with CMS, which means the Centers for Medicare and Medicaid Services, and the state of Tennessee. Through some calls and State Rep Powers was very instrumental in helping us with this. We got that debt forgiven, both at the federal and the state level. Then another thing we found, and I think I've told the mayor this, but it may not be public knowledge to everybody. There are documents called UCC-1s, which is Uniform Commercial Code Financing Statements, that anytime you buy a piece of equipment, if it's above a certain amount, the finance company can file that with the state. There were 4 open UCCs against Jellico Community Hospital. One of them was for lab equipment, and that lab equipment has been repossessed. And all these were done by Renovo. The second one was a $5.4 million. And this one is the one that's going to surprise you. It was on every piece of equipment. It was on all accounts receivable. It was on the license. It was on NPI numbers. So if they had defaulted, they could have come and gotten everything out of that. I got that one released by the bank. It was a bank out of Texas called BTH Bank of Tyler, Texas. I got that one released about 2 weeks ago.
Who was that left by?
Pardon me?
Who was that left
Renova.
by? Renova.
Yeah.
Who else?
Well, let me back up. There was 2 against lab equipment. There was one by everything in the hospital. And the last one is on a $280,000 mammogram machine. That mammogram machine is not in the hospital. So, but now, Renova owes for it. They may have taken it with them. I can't confirm that. All I can tell you, Tim has checked, our biomedical engineer has checked, it is not in the hospital. And Tim's a former hospital administrator. He knows what one looks like. Randy, our biomedical engineer, he knows what one looks like, so he works on those. So as far as I'm concerned, we're out of the picture on the UCC-1s. It's either been repossessed, released, or the equipment is not there and was not there when we took over the hospital.
Can I ask a question?
Yeah.
So those UCC ones, will not have to be paid off?
No,
Okay.
no.
Are they going to release them, or have they been
They-
released?
The three that I spoke about, where the equipment was repossessed, I've gotten those released. And the one with HBT Bank, I've gotten released. Now, I don't know, I haven't looked at the webpage in a week and a half, so I don't know if they've come off of the state webpage. They may or may not. I can't confirm
So
that.
there's
but-
two remaining?
There's one remaining.
One, okay.
And it's for the mammogram machine, so. Okay, then we have hit up with some barriers from the federal government. CMS, they have different regions in the United States. The one that governs Tennessee is in Atlanta. We want to open as a rural emergency hospital. And there's some criteria that you have to meet to do a rural emergency hospital. We have looked at a critical access hospital. That didn't, Boa Vita that was here, they ran it under a critical access hospital. They were not successful. And Renovo ran it as a fee-for-service hospital, acute care hospital. They were not successful. So with that, with population, we don't think we would be successful in doing either a critical access or a fee-for-service acute care hospital. So that's why we're wanting to do a rural emergency hospital. Because with the rural emergency status, we get paid, what, 3.6?
Yeah, 3.5, 3.6.
3.5, 3.6 annually divided up over 12 months from the federal government. That helps cover the indigent, the non-payers, stuff like that. But to be a rural emergency hospital, you've got to meet certain criteria. One of the big ones that is the problem right now is, did y'all know that you were urban? I mean, how many here knew that you were urban? Well, you are urban. You are part of the Knoxville MSA. So that makes you urban. Well, per the regulation that defines rural emergency hospitals, you can't be in an urban area. But there is a workaround. And that's, you have to apply, you have to show them that you are not urban, and there is a application, and it's called a Goldsmith modification. We fit everything that the Goldsmith modification requires to be taken. We don't get taken out of the MSA, but we get a waiver because of the condition, or where we're actually at. Tim here filed that last week. We have 60 days and we should have the result. Now, again, we're dealing with the bureaucracy of the federal government. We tried to call them today. 2 or 3 numbers that they had posted did not work. We did get to a number and they said they can't take our call. Please leave your name, your message, your phone number, and your email. So we just want to confirm that they got the application. So that got filed. The other issue was in 2020, a cost report was filed. To be a rural hospital, a rural emergency hospital, to make that transition, you had to have 50 beds or less in your hospital. They turned in a cost report that had 54 beds. The average daily census, when you run the numbers on their cost report, was 0.7 patients a day, which equates, if you had 256 patients, if you had a person in the bed in a bed in that hospital, one person, for 256 days, that's what that would equate to. And because they stated that you have 54 days, you had 54 beds listed, well, there's a little clause in the regulation says they have to be staffed. And they have to be staffed for 30 days. And if you aren't staffing them, if something happens, you have to be able to staff them, what, within 24 hours?
Yeah.
Yeah. I don't think Jellico could have done that. So we stand on pretty solid footing when we go in and make that argument. But we've got, the big issue is the urban, and that has to be resolved. And after that's resolved, we have a plan to engage CMS and see if we can expedite this. Now, they may run it out 60 days before we know anything about the urban. And getting it run up the flagpole, it's going to take some time. So true, that may push us into 2026. But let me tell you, some of the things that we have worked on, and I'm going to let Tim get kind of down in the weeds, is we have been actively pursuing strategic partners in this. First one is life science. And they're the laboratory people. They are out of Texas, and they are willing to come in. They can give us 3 options. And basically, all 3 of those options are, they're going to come and it's not going to cost us anything for them to put the laboratory back up and working. So that's good. We had our 3rd meeting today, this morning, with the University of Cumberland, just up the road here. We're working with them to bring in some of their faculty to work in the hospital while mentoring, teaching, coaching students up there. So the instructors up there, they get to keep, they continue to hone their skills, keep them up. And that's critical in anything that you do in medicine. Plus, we're going to be part of, growing the next crop of providers. Whether that's a PA, whether that's an RN, whether that's a nurse practitioner. And that went extremely well today. In fact, they gave us the nickel tour that turned into a 25-cent tour of the campus up there. We have worked with the University of Tennessee to get the transfer agreement. That is signed, sealed, and ready. So those are some of the strategic things we've done. And I'll turn it over to Tim and let him get kind of down in the weeds of some of the stuff. I mean, we've got applications, we've got people that we've interviewed, and I'll let him just kind of cover that. So, Tim?
Thanks, Jim. If I can, I'd just like to go back and emphasize a couple of things. We've taken responsibility for all of the utilities, so we've paid to have the gas turned back on, we've paid to have the water and electric transferred. All of that is off your plate. The $1.2 million, technically that license is still in your name, so guess who is responsible? That's gone, so it's not going to come back to haunt you or us. The stipend with the REH, the reason that exists, and I'm going to try and make this simple, but let's say I have a doc, I've got to have a doc there 24 hours a day. To make the math simple, let's say I pay that doc $100 an hour. That's $2,400 a day for that doctor to be in that emergency room, seeing patients or not. If we see 4 patients that day, and I can attribute $200 of each of those visits, that's $800 towards $2,400. I lost $1,600 that day. That's just a doc. Nurses, lease payment, insurance. That's why the rural hospital model fits Jellico Hospital so well. because it helps us account for and be able to manage those additional expenses. That's why care in rural hospitals is more expensive per patient than it is in an urban hospital. They don't have the volume challenge that exists in a small rural hospital. The rural designation, to be honest, that was a little surprising. We've done the research. We found the Goldsmith modification, that's all been submitted. The bed issue, I believe we've really amassed quite a bit of information to address that. Again, the issue there is going to be some time. So what else have we done? We've met with the Tennessee Health Facilities Commission. What was her name?
Lisa?
No,
No.
I forget her name. Anyway, she's the director of the Health Facilities Commission. She's been very supportive. She's provided us with a lot of good information. She's pointed us to a lot of helpful people. We have identified at this point at least 5 physicians who are willing to come and work at Jellico. We've received applications from at least 18 different nurses, local nurses, who want to come and work at the hospital. We've completed an initial assessment of the hospital, so that's all the systems, HVAC. We don't own the building, you guys own the building. We've put almost $30,000 into your building to fix the HVAC. We've still got a little more, and that's just for the ER and surgery side. That's not the rest of the hospital. For the rest of the hospital, because we don't want to grow mold, we've put a series of fans and dehumidifiers in to circulate and dehumidify air, so we're keeping the humidity about 65%, which should be adequate. We've started the process for the application for REH. We started the application for the change of ownership. That's when we found out about the $1.2 million. They would not process that application until that was taken care of. The other systems in the hospital, so the water system looks okay. We haven't had any leaks in the HVAC system. We still need to assess the oxygen and medical gas system. I suspect we may have some issues there. Otherwise, things look pretty good. We've evaluated what our needs are going to be for internet and telephone service. We've had Spectrum out and Cyphertech, and we've designed a plan for internet, telephone, security cameras, some other security devices so that we can monitor traffic in and out of certain parts of the building. We have established a source for biomed services. We've started the process of going through the equipment, identifying what is good for us to keep, what is functional and operational, and what we may need to decide what to do with because it's either not adequate or not functional. We've created our list of equipment and supplies that we're going to need. Excuse me. Supply-wise, they didn't leave very much. Equipment-wise, there's a lot of the smaller equipment there, but not much big equipment. So we're going to work through that process. We have, of course, executed a lease with you guys. For the REH application, we have developed a reopening plan, which is required. The plan was a little more challenging than typical because the criteria for the plan were to be based on transitioning from a hospital that was already open as a critical access or rural hospital and converting to a rural emergency hospital. That's not the case here. We're reopening from closed. So we had to approach that application a little bit differently. We've done the required facility attestation, we've done a letter of intent. We've identified access to care issues that we anticipate. We do have the transfer agreement with UT, like Jim said. We have a first draft completed of the CMS 855A. That's the application that we need to submit to CMS to convert to a critical access hospital. We don't want to submit the final application until we have cleared these last two hurdles. That's the rural designation and the bed count. I don't want to put us in a situation where we're going to submit something that we know is going to be denied. So we want to make sure that we have a full and complete application that meets all the requirements. We have paid to renew the hospital application, which would have expired, what, April something?
April 21st, I believe it
Yeah.
was.
The license is still in Jellico, the city of Jellico's name, but we have paid to renew it. We've started exploring electronic health records, which is a necessity. That's where you know, doctors and nurses and everybody keeps track of all your test results and visits and things like that. We also have had to request an extension of both the change of ownership application and the license. Even though we renewed it, it's been inactive long enough that we need to apply to extend that license in inactive status, and that's already been done. I think I'll stop there.
Well, where we're gonna go forward at, there's some things that we're gonna do immediately. All we got to do is put value in that building. We got to make that building value. We're looking at, if we can't bring the hospital soon, we're gonna establish an ambulatory surgery center in the surgery part. That way we can do scopes, we can do lumps and bumps, and, you know, minor stuff, you know, things that you would go to an ambulatory surgery center to get done.
And this isn't necessarily a big change.
Yeah.
This was
is-
originally phase 2 of our
Yeah,
project.
this was phase 2. We're gonna move phase 2 to phase 1 and maybe run them parallel together. The other thing, there's other two things, and today with University of Cumberland's brought one of these two fast forward for us. And we're gonna bring in a rural health clinic into the upstairs. We'll initially put it in the ER until we open this up rural emergency hospital. And today, talking with University of Cumberland, and they have mental health providers, and we can bring in intensive outpatient mental health services. So probably the RHC and the IOP, we can have running, up and running 60, 70 days from now. So, and then, again, we have been talking with other providers out there. We're right now entertaining bringing in, up in the old part, a medical rehab hospital. That's like if you have cardiac surgery and you need cardiac rehab, you know, hip replacement, knee replacement, stuff like that. There is a rehab area. Matter of fact, in Cookman, I think we got a 60-bed rehab hospital that is part of Cookville Regional Medical Center, which is now a 325-bed hospital. So they moved all of that out into another building and have it, it's kind of like a skilled care nursing facility. So, but that's what we're going to, actually we've started the track to, you know, get that stuff up and running. So, anybody got any questions on this?
No, I do apologize. I think that caught some people off guard with an article earlier in the week. I will do a better job of making sure you get that information before it goes out to the public. However, I want to emphasize that we made a promise in the beginning that we're going to be transparent, and we'll be transparent. So when information comes out, and it comes from any of us, it's accurate information.
For the IOP, is it solely psychiatric?
Yes,
Okay.
and it's outpatient, so.
Okay.
Anybody got any questions for